Hi, I'm Margie Morgan. I am the medical director for microbiology at Cedars-Sinai Medical Center in Los Angeles. And I have the pleasure of talking to you today about the Diasorin Liaison PLEX system, which we've had a good bit of experience with. So I hope you can find the information I relate to you helpful. So we'll start this presentation now. So this is the title of my talk. It's about the liaison plex at work and how rapid respiratory testing can drive diagnostic stewardship. This is my medical center, and the reason I bring this up is because all of us are in different types of situations, and sometimes we have to adapt testing to our own particular situation. So I'm in Los Angeles in a very big nonprofit academic healthcare center. We have a very diverse population in Los Angeles. We're about 920 beds, but we always seem to be at 1,000. It's a level 1 trauma center. We have lots of major services such as solid organ and bone marrow transplant, a lot of cardiology and orthopedic surgery, cancer centers. We're not big on pediatrics, so that might have something to do with the way we look at this test. Outreach testing, we do one for one hospital. We also do physician offices and clinics, and we're the Region 9 Special Pathogens Program. So that kind of gives an overall picture of what kind of medical center I'm at. So you can imagine that I might have needs for my respiratory testing that perhaps is different in your situation. I do have a microbiology laboratory that is on campus. We have 55 staff members, 35 licensed CLS, and we provide 24/7 coverage. And as I said, I'm going to talk to you, my pleasure, about the liaison plex system. And it is really a very novel system, as you'll understand as we move into it. And it's particularly interesting because it can do what's called flex testing, which I will explain to you as we move forward. So let's start with my liaison plex or flex adventure, which began in 2016. So I have been using the system for about a decade. So what was my problem at the time in 2016? Well, there was lots of upper respiratory tract infections, which accounted for millions of physician visits annually in the US. Most of these, however, were viral infections. But unfortunately, without doing any testing or anything else, most patients were prescribed antibiotics. And this is one of the reasons why we started seeing a lot of antibiotic resistance happening around this time, as you see in the graph on the right-hand side. The community-acquired pneumonia also sometimes required hospitalization, with a particular problem in older adults. Viral pathogens were also more frequently detected in this patient population as well. So I needed a solution. I need a rapid, focused molecular testing for viral pathogens to assist diagnosis and decrease antimicrobial usage. So how is this testing going to be performed? So I had some choices to make in my microbiology laboratory. I could do choice number 1, which was choose an instrument with one-size-fits-all panels. This was usually a very expansive multiplex panel that could test any respiratory infection where there'd be viral or select bacterial pathogens. The fixed panel with a fixed purchase price, which was quite pricey. Large number of targets on the panel may be more than you need, and certainly more than the physician intended to order, but it's a fixed panel, so you have to do what you have. The second choice at the time was multiple instruments and send-outs. This would provide more select viral targets to match our physician orders, but it might be tested on multiple panels or instruments. Maybe we needed to have more than 1 or 2 instruments to supply all these needs. And sometimes if we wanted to do select target testing, we might have to do send-out testing to a reference laboratory. We also had other considerations in our setting. We are very patient-centric here. We're sensitive to laboratory costs that patients might encounter, particularly in an outpatient setting where insurance may not pay. A lot of our patients might have just catastrophic coverage, and their services, their outpatient laboratory services, are not covered by insurance. Insurance plans require patient copays, or do not pay for certain types of services. Insurance and payer. Boy, there has been a change and shift in medical reimbursement to laboratories over the last few years, and particularly it started back around a decade ago, that reduced reimbursement for laboratory testing by millions. So we had to do a targeted stop of reimbursement for large non-focused respiratory multiplex panels. They were not paying for those large panels at all. There was no insurance reimbursement to us or to the patient. So placing the patient burden totally by cash pay onto the patient. So this became a very big issue when we started making decisions. My problems also continued. As we started moving into doing respiratory testing, our first molecular test system that we chose to use was that first one I mentioned, a multiplex respiratory pathogen. We were doing so many because our institution is so large and we have so many outpatients and doctors' offices that we serve, that the cost that we were spending to purchase these panels prompted our hospital administration to request that we decrease usage. This is the first time I've ever had a direct communication from a hospital administrator saying that we need to halt a practice due to cost. Eventually, total reimbursement was stopped, and this really created a financial burden. So, needless to say, we needed a replacement respiratory assay that was less expensive, but we wanted to maintain the high quality and capable of detecting the multiple pathogens. We wanted to go with one testing platform. We needed to have most, if not all, tests reimbursed by insurance agencies. And we wanted to have clinical and financial data to support a positive acquisition plan and prove to our hospital administration that we were using a new test that was more cost efficient. So our first 2016 solution to our dilemma was to go with the Veregene RP PLEX. This was a multiplex molecular panel to detect the primary respiratory pathogens that we needed to detect. It had 13 viral targets and 3 Bordetella targets. You can see the test unit pictured on the right side. For the time, we thought it was a wonderful size, but for now you would say that is quite a large unit with many modules. But also, the Veregene RP PLEX that we started in 2016 had a very unique twist that gave us just what we needed. You can flex test on this system. What is meant by flex testing? Well, this means that you can create your own customized panels with the number of targets that fits your testing and financial needs. This was truly unique for the time, and we thought that that could be a great solution to solving our testing and economic issues that we were facing. And of course, now this Veregene RP PLEX that we started using in 2016 has evolved into the updated and improved Diagnostic LIAISON PLEX in the picture on the right-hand side. The LIAISON PLEX has really moved beyond the original system. It has the same testing flexibility as the original Veregene RP PLEX, but with much greater operational efficiency. As my title of my talk suggested, we're trying to improve diagnostic stewardship, and this test system can certainly help with that. You can make custom panels that align with patient symptoms and assist with diagnostic stewardship. You no longer have to test a huge multiplex panel to get the 2 targets in which the physician is really looking for. You can create a custom panel with just those 2 targets that you can be used in your testing. Also, fiscal responsibility with this system. The flex testing enables alignment with reimbursement guidelines. You only pay for the relevant results released through a credit purchase agreement, so it also meets our fiscal responsibilities to our institution. And how about operational efficiency? Well, as I will explain further, it's a very simple sample to answer workflow on this instrument, and everything is stored at room temperature, which is very, very helpful when you're getting large numbers of supplies. This is the LIAISON PLEX cartridge on the left-hand side. You can see it's just one unit. That's all there is. There's not different pieces and such that needs to be put into the instrument. This is the complete cartridge. What samples are tested on this system? The sample of choice are nasopharyngeal swabs collected in either universal transport media or viral transport media. The sample volume is 300 microliters. The swab used is usually a nylon flocked swab. This seems to be and is the swab of choice now used in the United States for collection. Does a very fine job with good elution into your transport media. There's internal controls on this cartridge for extraction, amplification, and hybridization. When you order the kits, they come with one box with 12 single-use cartridges and 15 transfer pipettes. Shipping and storage is at room temperature, which, as I said, makes it very nice when you're ordering large numbers of supplies. The time to result is approximately 2 hours, enabling a fast turnaround time that can help your physician perhaps have better and more prompt treatment. And the extraction method is on board. Everything is contained within that cartridge. This is the assay is powered by an innovative and proprietary technology known as a nanogrid. This technology delivers sensitive and highly specific multiplex detection. It's an integrated cartridge, so all of your DNA, RNA extraction, multiplex PCR, and microarray detection is in one consumable pictured there. And as I keep saying, it's ambient storage. So you can see in the cartridge, there's an area for hybridization, amplification, and extraction, and microarray. You can also see on the far right-hand side the sample port. This is just the magic door that you open to insert the specimen. So everything is very nicely contained in this cartridge. How do you set this up? Well, it has a very simple workflow. You can see that step one is you just transfer the sample from your universal transport or viral transport media. You open the door and insert the sample into the cartridge using the pipette, which comes with the test system. So you do not have to have any supplies except for what comes with the test itself. The second step would just to be simply scan the sample ID and cartridge ID into the system. This makes it very, very simple and fast. And then the third step is to load the cartridge and initiate the run. And of course, the results will be reported approximately 2 hours after the run starts. What are the targets on the LIAISON PLEX system? You can see it has a very nice variety of both viruses and bacteria. It has a lot of the viruses that occur in the respiratory season, such as influenza A, influenza B, and human metapneumovirus. That target has been particularly important this year in California because we've seen a very big increase of human metapneumo. Also notice that it can subtype your influenza A's to H1 and H3. This has also been a very, very helpful to us in California as well as we combat the H5N1 outbreak among our cattle and chickens. Also, there's adenovirus, parainfluenza virus, human entero and rhinovirus, RSV, and a severe acute respiratory syndrome, of course, we know as COVID. On the bacterial side of things, it gives you some very nice targets for Bordetella. Unfortunately, in the United States, we're still seeing some Bordetella infections, and so this has been extremely helpful, and it has chlamydia pneumonia and mycoplasma pneumonia. How does the LIAISON system look and work for flex ordering and reporting in the United States? Well, the first thing, a physician will order a focus test panel. And so we get the order from the physician, and let's say they're wanting our panel for influenza A, B, RSV, and COVID. So we insert that into the system. We select the appropriate panel based on the MD order via the touchscreen. We receive and report the results to the physician. Okay, so let's say the physician gets the results of our influenza A, B, RSV, and COVID, but they're all negative. And he goes, could this possibly be human metapneumovirus? And then he can call and ask for us to open the additional targets. So if the physician orders additional targets, we can release additional FLEX panel results with no retesting needed. And that's really the key. Everything is stored within the system. You do not have to retest the specimen. The targets are already within the system. You just have to open them. And that's the beauty of the FLEX system. So how does this work with the FLEX credits? Some people think this might be confusing, but really it's not been difficult to implement, and we have not had problems in microbiology or with our finance department handling this FLEX testing type of billing. You purchase FLEX credits from DiagNostics, about 100 per purchase, to prepare for future release of additional targets. The initial purchase price for LIAISON PLEX includes testing to up to 7 results. If additional results are released, the FLEX credits are used to pay DiagNostics for the additional released results. If you run out of text credits, it is monitored on a software level, and you can put in additional orders for additional FLEX credits. And they will be sent to you, and they'll send you a QR code that you can that is emailed to you, and that's the way you add additional FLEX credits to the system. Your representatives can certainly explain to you in more detail how all this works, but I do say it has not been a problem, and we've been able to use this system quite effectively. Depending upon your own medical center and what your needs are, you're going to develop focused FLEX panels. It can be your own creation. These are the panels that we've created. You may look at these and say, well, these really is not what I want. Well, that's fine. You create your own panels to suit your needs in your microbiology laboratory. We used information, historical ordering patterns, and seasonal virus variation to help us create these panels. We also had discussions with some of our infectious disease physicians in both adult and pediatric areas, infection preventionists, and our antimicrobial stewardship committee, and they helped us create our panels. We created a flu panel that had we have used tremendously for subtyping influenza A from if we are using another method as our primary. This is a way we can go back and type our influenzas, and it has been very, very helpful because our state health department in California is still mandating that we provide influenza typing. So that's why we have our FLEX panel. We have a para-influenza panel. We have a Bordetella pertussis panel, which has been extremely helpful. Unfortunately, we still see Bordetella in our region. And so this is like approaching a single target focused testing panel just for Bordetella. We have various viruses that happen during winter, such as the human metapneumovirus that I was speaking to, the atypical pneumonia panel to address Mycoplasma pneumonia requests, and then we have our seasonal influenza A, B, RSV, and COVID panel. So as I say, these are the panels we created, but you can be as creative as you like and create the panels which will work best for you. How did LIAISON FLEX help testing? Well, the physician adapted to focusing ordering, leading to improved diagnostic stewardship. They would order a focused LIAISON PLEX panel for their desired pathogens based on the patient's symptoms. And then if the physician calls back for additional pathogens to be tested, we would release those additional results without having to retest the sample. So it was a very fast turnaround time. So this worked very well for diagnostic stewardship in our medical center. We also eliminated many reference laboratory send-out tests. We were able to create focused panels for Mycoplasma pneumonia and Bordetella pertussis when those specific orders were the ones given by the physician. The LIAISON PLEX panels are reimbursed by insurance plans, so we did not have to worry about a financial burden on our patients. If the patient happens to be uninsured, it is a much less expensive panel than if we used a very large multiplex panel for testing. It also decreased our laboratory costs to meet our financial goals. This is the algorithm that we created in our medical center, but you might have a different way of approaching things. We use the LIAISON PLEX respiratory flex panels on all of our adult non-ICU patients. We also get several requests from outpatient clinics and physician offices, and testing, of course, from our emergency department. So these are all performed on the LIAISON PLEX method. So we use the focused testing using customized flex panels that are reimbursed by insurance agencies. We also have kept on the multiplex large respiratory panel, but we use it in much, much less numbers. We only use it on pediatric and adult intensive care units. From discussions with physicians, they wanted us to maintain this broad, non-focused testing panel and argued by caregivers to be necessary for the critically ill. Sometimes we do have to give in and certainly listen to our physicians, and we decided that this would work out best for us. But even though we were maintaining some of our multiflex respiratory panels, we reviewed back in 2016 if we used a combination testing of that algorithm that I just talked about, with a lot of the flex testing being done in combination with having to perform some of the multiplex testing, would it still meet our financial goals? You can see the three scenarios that I've set up there. Scenario one would have been if we maintained our multiplex panels for all of our testing. The center scenario is if we used our combination algorithm with our percentage of testing and ordering, how that would have come out. And then on the right-hand side would be if we only used the RP Flex by itself and did not offer the multiplex panel. You can see the different prices that are outlined there as outcomes. And you can see the scenario 2 with the blue arrow is the path that we chose. It was far less expensive than using our multiplex respiratory panel, and administration felt that we did meet our financial goals by almost cutting in half, or a considerable amount of money was saved by going to this new algorithm. So we considered our mission was accomplished. We offered focused testing for most requests, but we still offered multi-target testing for the ICU patients. But doing this in combination, we saw a significant decrease in cost, and were still able to meet our physician orders, and they were very pleased with the outcome. These are just some of the questions that I thought you would ask. So if MDs can choose between a targeted flu, RSV, COVID test during winter or a broad multiplex respiratory viral panel, what do they order? Well, as I said, our intensivists and pediatricians are given permission to order a broad molecular plex panel for diagnosis. But our ED, general medicine, and outpatient caregivers are restricted from ordering the broad multiplex panels. We did education and discussion when we moved into our new algorithm with select physician groups. We encouraged this kind of step-down testing to the flex testing using more focused approach, and that we argued that it would improve diagnostic stewardship. But it certainly was a change in practice. They were very used to just putting in one respiratory order for all organisms known to exist. And so it was a little bit of change in the thought process that we had to educate. We also placed the LIAISON PLEX panel at the top of our viral ordering in our computer system. So it was the first panel that they would see, which was the flu, RSV, COVID test during the respiratory season. It is amazing how they tend to go just for what's at the top of the panel list. And so this really helped us get select orders for the Flex system and them not having the multiplex ordered. We also did soft computer stops on broad multiplex panels for the non-ICU patients that were in-house, and they got a reminder that they needed to order the Flex panel. And we also had a hard computer stop on multiplex panels ordered from outpatient and ED. We thought that was only the right thing to do to alert them that these were not covered by insurance plans and that the patient would be at having to pay for these tests. We wanted them to be continually educated to that fact. So using this type of education, we have successfully implemented the Flex test, and we've been successful in maintaining our algorithm. More questions. Is it unethical to test a broad LIAISON PLEX panel where the instrument could detect a positive target, but the information is hidden? Well, if you test the targeted or focused panel that is requested by the physician and report the requested results, you're really not doing anything unethical. You are performing the requested test. The second one, has our billing department had any issues handling the reflex testing and/or CPT coding? We've not experienced any issues with this CPT coding of the Plex panels on patient billing, and the Plex panels are reimbursed by insurance payers in the US, and the multiplex panels are not. So overall, everything has worked very well with our billing department. And I thank you for listening to my presentation. I hope I've given you some valuable information about how Flex testing can really help you in your laboratory. And I thank you for listening to my presentation.